It gives immense pleasure and honor to introduce our next moderator, Professor Dr. Prasanna Kumar Shetty K. Sir is currently working as senior most professor in the Department of Obstetrics and Gynecology and head of Kshema IVF Fertility and Reproductive Medicine Center, K.S. Hegde Medical Academy, Nitte University, Mangalore. And Sir worked as lecturer at CMC Vellore from 2000 to 2003, and he's done MD OBG from Bangalore Medical College and MBBS from Karnataka Medical College, Hubli, and Karnataka University, Dharwad. And he has obtained his advanced IVF training for clinicians at BACC Healthcare, Bangalore, in collaboration with Merck and Serono. And he has done his observationship in perinatal medicine from Maimonides Medical Center, Brooklyn, New York. And currently, sir is also serving as president of Mangalore Obstetrics and Gynecology Society. I welcome you, sir. Over to you.
Thank you. Thank you, Tejaswini, for that kind introduction. And thank you, IHERA, for having me here today and for these wonderful sessions being conducted today for all the embryologists from all over the country. Thank you, Dr. Ved Prakash and Sanket and all the IHERA organizing team. The next session is about quality control in embryo transfer. So embryo transfer is a deceptively simple procedure, perhaps the most important and crucial step in the entire ART process. Deceptively simple procedure, but I remember one senior reproductive medicine specialist telling me that your first 25 to 50 embryo transfers are going to be really stressful, to which I fully agree. And today to discuss this very important topic, both on from the point of perspective of embryologists as well as reproductive medicine specialists, we have a very distinguished speaker, Dr. Priya Bhave Chittawar. Dr. Priya is a reproductive medicine specialist practicing in Bhopal. She's trained in one of the most prestigious Christian Medical College, Vellore, of course, of which I also have very fond memories. And she has expertise in reproductive medicine and minimally invasive reproductive surgery. So over to you, ma'am, Dr. Priya Bhave Chittawar.
Priya ma'am, please unmute yourself.
Am I audible now, Doctor?
Yes, ma'am.
Thank you so much for that kind introduction, and I really enjoyed all the sessions by all the esteemed speakers. And to talk about quality control in embryo transfer, I think this is something which is really very, very important, because as ART specialists, all of us struggle with science which is growing. And while all of us would like to live in a times where we can boast of 100% success rate, all of us know that our success rates are modest. And that is what makes all of us have that itch or have that restlessness to, aim at perfection. Because as Rajvi madam said, there are certain things which are not in our hands, but the rest of them which are in our hands, we want to be perfect in them. And as Lord Chesterfield quoted, aim at perfection in everything, although in most things it is unattainable. However, they who aim at it and persevere will come much nearer to it than those whose laziness and despondency makes them give it up as unattainable. Now, quality control is actually a very small part of the concept of total quality management. Now, total quality management was a concept which was actually floated for the industry by Ron Fitzgerald. And what it means is that it is not only the clinician, embryologist, but it is everyone, every stakeholder, right from your cleaner to your administrator to your clerk to your assistant. Everybody is involved in a philosophy which aims at continuously improving your service to your patients or to your clients. And this is not only just an intent, but it is based upon hard data. That means you look back at your own performance and you try and improve it and bring it up to a certain standard. So all of us know about the plan, do, check, act cycle. And what happens in our branch is that, you continuously set up a standard for yourself. You set up maybe an implantation rate of say 25% or a fertilization rate of 90%. You plan to attain it, you do it, you check whether you are able to do that or not, and thereby you take yourself to the next level. So every time you are in this cycle, you are actually finding yourself one level higher than where you started. So quality assurance is actually the total sum of the systems that are required to establish a product that meets the quality as determined. Quality control is actually what you do in order to assure quality. And quality improvement actually includes not only quality control, but also risk management, quality management, and management of serious adverse effects or serious adverse reactions. Now, earlier, the concept of quality was that errors are an integral part of quality. So it was assumed that, we will make mistakes, we will learn from them. These mistakes were called as non-conformity. So when you don't conform to your SOP, you record it as a non-conformity, you correct it, and thereby you improve yourself. But there is a zero defect approach in the industry which says that defects are caused because of flaws in the process or activity, and we should all aim at no accidents, no defects, no breakdowns, and no waste. Now, when you think of it, can we apply the same zero error or zero defect policy to ART? So this is something which was made for factories. So when they manufacture things, they want that the product should have zero defects. So are we actually baby factories that we are making babies? And so, we also are trying to copy that from industry. But actually, when you come to think of it, the process of ART is an industry which actually has zero tolerance to any mistakes, especially the process of embryo transfer. For example, any small problem in embryo transfer can be extremely disastrous. All of us remember an incident where I'm sorry, I think my presentation is stuck. Yeah. Yeah. So there was a mix up in the UK wherein there were 4 or 5 embryo transfers planned, and then wrong embryos were implanted in 2 successive women. And this led to an outcry, and actually this unit was shut down. So actually in the process of embryo transfer or in this specific procedure, there is absolutely zero tolerance to any sort of mix up or any sort of error. And so that is why this whole process of embryo transfer is so precarious. And you're going to put it back, and one small mistake can actually collapse all of it. So what are the variables that we are trying to control when we are trying to do an embryo transfer? So I would classify it into 2. One is the things which we do for patient and embryo identification. I think this is as, if not more important than the clinical variables. Clinical variables are, of course, patient factors, operator factors, and the lab factors. Now, whenever we talk of embryo transfer, it is the culmination of that entire process of IVF, the pre-IVF workup, the counseling, the retrieval, and now finally the patient is at the stage of embryo transfer. Most of the times what happens is that we only consider the process in isolation, but what is more important is the counseling that goes behind it, because most of the confusions, most of the incoordinations, most of the problems can be managed if you have a proper protocol for counseling. Now in our unit, it is always the nurse manager who talks to the patient first, then the embryologist, and then finally the clinician talks to the patient. Now, this is the time where we take the consents not only for transfer but also for cryopreservation. Now, the role of nurse manager, I feel, is extremely important, because small things like taking the medications on time, omitting the morning dose of vaginal progesterone, that is, the preference for many clinicians, they have to come with a partly full bladder. They can have some breakfast and come. In many units, it is so common that the patient is fasting, the clinician is busy, and the patient is so cranky because nobody told them that they could eat and get full stomach for the embryos. Very small things. Most of the clinicians, they are not important to us, but they are extremely important to the patient. So a good nurse manager or an IV coordinator should be explaining all these things. And a very common thing is that once the pickup is over, the sample has been given, the husband usually disappears. And when it comes to the consent on that day, the husband is not there for the consent. So make it a point that if the husband is not going to be there, the nurse has taken the consent prior, and you explain or at least talk to the patient's relative regarding the number of embryo you're going to transfer on phone. The embryologist always should speak to the patient before embryo transfer. They are the people who have created these embryos. They are the people who can explain the nitty-gritty, the small things. What was the number of embryos? What is the quality? What is the prognosis if we transfer today, or we freeze, or we take to blastocyst? And the embryologist in our unit at least explains to them about our multiple pregnancy rate. Implantation rates are different across the clinic. So our embryologist has the data with them of our multiple pregnancy rate with these quality of embryos over the last 1 year, and the patient ultimately decides how many embryos are to be transferred. Now, when the patient comes to us, not only is it important to think of how many number of embryos we have to transfer, but also about their coexisting medical conditions. Are they on thyroid medication? Are they on any antihypertensive? Does their diabetes medication needs to be changed after the embryo transfer? All these things have to be very. Most biggest question which now the patients have is whether they should go for the transfer or the frozen transfer. It is very common that when you tell the patient that, okay, we want to do a fresh transfer, they are extremely disappointed because they have heard somewhere that frozen transfer is better. So it is very important to give that time to the patient, explain why we have decided for a fresh or a frozen. And in case it is a fresh transfer, is there any chance of OHSS? What are the precautions she has to take? And again, once we put back the embryos, the job for a clinician, at least in my mind, is done. But actually, the patient is extremely anxious as to the precautions. हम कितना सीढ़ियाँ चढ़ सकते हैं, हम क्या खा सकते हैं, हम खांसी कर सकते हैं कि नहीं, हम ट्रेन से ट्रैवल कर सकते हैं कि नहीं. So they have a lot of questions in their mind, and it is always good to answer or have your counselor discuss them. Now, the next and most important part is two parts, that is double checking and double witnessing. Embryos do not speak and they do not say to whom they belong. So whenever the patient comes to the embryo transfer room, always a double ID check is made. Now, one of the person who is doing the double ID check has to be an embryologist, and one person has to be from the clinical side. In an Indian scenario, it is often very odd for the patient to be asked their name, and they suddenly lose confidence, because one patient told me that आपने हमारा इतना इलाज कर लिया, अब आप हमारा नाम पूछ रहे हो, आप हमें भूल गए क्या? So it is very important that while we are asking them their name and their husband's name, we have to tell them that we know your name, but we have to do this because of the documentation purpose. Now, as the embryos are being loaded in the ET catheter, we always have one junior embryologist who is witnessing this and putting a signature. Just seeing is not enough. They have to sign on the embryology worksheet that they have witnessed. And finally, after the labeled catheter is handed over, the embryos are transferred, and this is again witnessed by a nurse, which is again recorded on the worksheet. I will share the sample of our worksheet with you. Common causes of error in are, you take a patient inside and she is squirming, I have a full bladder, but when you actually take her, you are not able to visualize, so you send her back, but embryologists have not been informed. So what we have done in our unit is that the double ID check, one person is always from the embryology side, and there is a glass door between the lab and OPU theater, so any patient coming in and going out is visible to the embryologist as well. Now, these seem like very small things, but these are the places where you can have a near miss, or you can have an accident where the embryos can be mistakenly transferred to another patient. Now, patient tables. most of the times all of us are sure about the direction, most of us are sure about how to do the embryo transfer, we've done a mock transfer, but there are often situations where the patient is very obese, she's had a previous surgery and the uterus is ventrifixed, there's a large uterine mass which is pulling up the uterus, there is some disability like maybe polio or some hip problems, or there are some patients with vaginismus who won't allow you to put in a, there is some barrier wherein your visualization of the cervix is very difficult. There are certain cases wherein the, I'm sorry, it's yeah. In certain situations, the cervix is visible, but because of the position, either anteversion or retroversion, or there is a false passage, or sometimes there is a big cervical crypt, especially in those multiparous patients where the cervix is very big, or there is a polyp which is not probably seen on external os, but it is there, it is obstructing the path of the catheter, and this leads to a failure to cannulate. Now, what we do in these positions is, of course, we should have done a mock transfer before, but sometimes in obese patients, those with previous surgeries, we do a knee chest position. This kind of helps us, it brings the cervix anteriorly and it helps you visualize the cervix. There is a special long speculum which we have for obese patients, which has got really long blades. So in case it is a very deep seated cervix, we are able to visualize it. Universally, I do an afterloading or a two-step technique wherein I put in the external catheter and then the loaded catheter is brought in and inserted. Sometimes if I have a doubt, when I put in the external catheter, I use an extra inner catheter to just make sure that my inner catheter is going in and then the loaded catheter comes in. It is very important. Sometimes what happens is that there is a very small external loss. So the conventional Cook SIVF catheter has got a very bulbous tip, so you are not able to cannulate with that. So for that, we always keep a catheter on the shelf, like a Wallace catheter, which does not have a bulbous tip, or a Sureview catheter, which has got those small bubbles in the which are visible very well on ultrasound. It just lights up on the screen. Sometimes we do have to use a metal slit, which is made specifically for a catheter. Now, in all the patients where I anticipate a problem, off late we have started giving an atosiban injection prior. It causes the uterus to relax, and even when you hold it, there are no uterine contractions. There is emerging evidence on that, but this is our practice at present. Now, the technique, again, it is slightly outside the purview of this, but I think for a quality control purpose, we have to make sure that we are always doing it with a partly full bladder. If the bladder is really full, then the uterus becomes very, very distant from your probe and your visualization is not that good. And another very important thing is that while all the books would like us to aspirate the mucus, we actually do very minimal mucus aspiration, because when you aspirate the mucus, you inadvertently touch the cervix and you cause some bleeding, and this actually messes up your transfer. The outer catheter, we just put it at the internal os, the inner catheter is brought in by the embryologist and put in. What I practice since the last almost now 7 years is that I put in the embryos and I immediately withdraw both inner and outer catheter. I don't wait or turn the catheter. I just withdraw it immediately without withdrawing its tip inside the outer catheter. Now these were the patient variables. Now what are the operator variables? Does experience of the operator lead to a difference in the outcome in embryo transfer? Well, actually it does. All of us know that embryo transfer is very, very critical, and I think across most units in India, embryo transfer is usually done by the most senior clinician in the unit, and usually it is not a procedure which we can give to the new people who join our unit or to the trainees in most cases. And as you can see, the evidence also says, sorry, how much time do I have? Okay.
5 minutes.
Okay, so I'm just about to finish. And the minimum number of embryo transfers which are required for proficiency, this paper would have us to believe that around 30 to 40 embryo transfers is what is required to reach an acceptable cumulative pregnancy rate. What we do in our unit is that we teach our fellows to do embryo transfer on our IUI patients. So we take catheters which are sterilized, we load the bubble without the embryo, and before they do an IUI, they practice doing an embryo transfer, and after that we do an IUI on the same patient. So this gives them that feel of pushing This shows them where their bubble is actually landing up, how much pressure they have to use, and this is very useful. Now, there are three grades of embryo transfer which we subjectively grade. Grade 1 is no blood or mucus, grade 2 is slight staining, and grade 3 is heavy staining, or if there is staining on the outer catheter also. In all our forms, we always mention for the retained embryos as well. I think my presentation, okay. Now the lab variables, there are a lot of them, but main for this presentation, I would like to stress on the loading technique and the loading to discharge time. For purpose of comparability, we always use the instable system, because the earlier system of grade A, grade B, grade C, it is not actually comparable across clinics. So for within the clinic, we always use this system of grading. For the air quality, we have a protocol of checking particle counts twice a year. HVAC filter change is done yearly, and we control the number and movements of the personnel. Now, surface temperature again in embryo transfer is very critical, because surface temperature may not be the same as dish temperature. Plus, due to the laminar air flow hood, there could be a draft and cooling. Now, the major game changer for our unit has been the embryo loading technique. The conventional technique, what earlier we were using even in Vellore, was a fluid technique. So the entire catheter used to be filled with media, but now we have shifted to very little amount of media, that is hardly 15 microliter, and most of the catheter is loaded with air, and this has given us really amazing results. Now, the time interval between embryo catheter loading and the discharging also ideally should be less than 120 seconds, and this gives better results. What we do is we do an yearly and monthly audit of KPI, yearly filter change, accreditation renewal, and ongoing QC, that is reporting of non-conformities and corrective action. Now, for example, this is an old slide. This is from 2016. You can see that in October, suddenly our self-cycle pregnancy rates fell down to 8%. So out of 38 patients that we did, only 3 conceived. But in the donor cycles, the pregnancy rates were okay. They were still acceptable. They were 36%. They were lower than the previous month, but they were okay. Now, when we actually looked into this, we found that it was all because we had a lot of older patients, severe male factor, and poor prognosis patients. In another situation, we found that suddenly in October again, we had a very sharp fall in our pregnancy rate, that is 13%. And this was really because the previous cycles, you can see it is 46, 57, 60%, and suddenly in October it has dropped down to 13%. And what we found, and what most of us found at the same time across the country and many parts of the world, is that there was an issue with the culture oil. The moment we changed the oil, the next month itself our pregnancy rates picked up, and they were almost 67%. So with change in oil, again the implantation rate and clinical pregnancy rate picked up. Now, one small example of how we deal with non-conformities. This is a non-compliance report form. Now, this is not specific for embryo transfer, but I think the philosophy holds for all the sample collection. Now, the incident, what happened is that sample of one patient was supposed to be given for IUI, but the form collection, it was labeled for semen analysis. Now, usually the practice was, before we started doing this, was to scold the person, to take some action on them. But we found that this does not work. It is usually the system which is at fault. So what now we have done is we have a color coded form for collection of semen analysis, for semen freezing, and IUI and IVF. So 4 different colors. If a patient is for semen analysis, he fills a white form. For IUI, it is a pink form. So now these incidences have come back to 0. The second thing is that we have an IUI trigger register. So the lab knows 1 day prior what are the list of patients who are to be taken for IUI. The second example is a non-conformity which occurred again in 2009.
Ma'am,
yeah,
sorry to interrupt, ma'am. Time is up.
Okay, so I'll just share my embryology worksheet with you. So here in the worksheet, you can see that we have an ID check. In the embryo column, you can see there is an ID check 1 and 2, and these worksheets are audited. Our guideline is that unanticipated difficult transfers must be less than 10%. Double witnessing has to be checked in all forms monthly. Grade 1 transfers, that is without any staining, should be 80%. And embryo transfer forms, all the consent forms must have number of embryos which are mentioned and all the signatures. So this is audited monthly. So to conclude, for embryo transfer, it has to be a 0 error policy. The pre-transfer counseling, double checking, double witnessing, they are very, very important. You have to standardize the procedure, anticipate all the problems, and most importantly, measure and monitor your outcomes, because that is what all the IVF clinics look for. Thank you so much.
Sir, Prasanna, sir. Dr. Prasanna, sir.
Hello.
Yes, sir.
Hello, pardon. Thank you. Thank you, Dr. Priya, for that wonderful talk. Are we having any Q&A? No?
Currently, there are no questions, sir. I think
Any questions
you
from
can
the
take one or two
audience?
questions. From audience, currently there are no questions, sir. I think you can take one or two questions.
Dr. Priya, I have a question myself. In case of difficult transfers, I mean, like, do you do routinely a mock transfer at the time of embryo transfer?
No, not a mock transfer. So we've usually done a mock transfer prior, or the patient has undergone a hysteroscopy or an IUI with us. We do an afterloading technique. So I put the outer catheter first in for all the patients. Once that crosses the internal os, only then we ask them to load the embryos. Rotating the
Yeah, sometimes people put a dummy inner catheter. Some clinicians do that. So, what is your opinion on that?
Sometimes, in case I have a doubt whether I will be able to cannulate or it's been difficult, I use an extra inner catheter. It's always on the shelf. But usually, occasion is not there to use it. But yes,
Yeah.
I was trained like that. We were taught to insert it, rotate it by maybe some few degrees, and then take it out. But after working with some senior embryologist, I worked with Dr. Bharat Shah, and what I found is that his technique is very good. He just injects and he takes it out immediately. So, and in fact, my results have improved after I started using that technique. So I don't rotate the inner catheter anymore before withdrawing.
Right. Many studies have also pointed out that turning it and waiting for a couple of seconds actually do not modify the pregnancy outcomes. Thank you so much. And are there any questions from the audience? Thank you, Ahira, for the opportunity. Thank you for having me.